So they are prepping for the operation now, and yeah, we're in the operation.
Okay, we are ready now. Can you hear me?
Yes, I can hear you.
Yeah, Dr. Ye is ready.
Okay, okay.
Okay, please start the imaging. We're all set up for you.
So this is initial CT scan of the patient. So the doctor is placing the marker paper on the thorax wall of the patient.
Is the patient in conscious sedation? Do you give any drugs before the treatment?
All right. We can. We can see the lesion which is located at left upper lobe, left lung. So Dr. Ye is making the pre-operation plan. So we can see that the diameter of the lesion is around 14 millimeters.
Do you give any drugs to the patient before the treatment?
Generally, patients just receive moderate sedation, and no drugs.
Any prophylactic antibiotics?
The patient we use local anesthesia by lidocaine. And the
Yes.
distance
apart from that, do you give any antibiotics?
No antibiotics. No, because this lesion is small, so it's not necessary. We can notice that the distance from the chest wall to the lesion is 94 millimeter. And the distance of the chest wall is about 50 millimeters, which is very important for our future for our next procedures. So we usually advise to take this two distance to calculate these two distance.
This lesion has been biopsied before?
Oh, no biopsy, because
It's PET positive.
it's very typical. It's very typical in CT scan. It's just a metastatic lesion, and she just have colon cancer history, and the lesion is gradually enlarged in the last few months.
Normally, Alex, would you still take a biopsy when you access it for ablation?
For primary lung nodules, we must have biopsy. But for metastatic lesions, it depends.
So you always
Do you always do microwave, or do you use other ablation devices too?
We mostly use microwave. Yeah.
Why?
Do you have any coaxial pattern?
Sorry, grab.
Do you have coaxial system?
Coaxial system.
Coaxial system. Coaxial, yes.
Correct.
Meaning that you put one needle inside the other instead of puncturing
Yeah.
directly.
Yeah, because if you have
Sorry, I
coaxial, it is easy to take
can't
a
quite
biopsy.
understand. I can't quite hear you.
我们会用
Okay, it
扣
is-
管针嘛？
Core bio. Yeah,
Yes,
we use a
Okay.
core biopsy.
No. It's not a biopsy. It's a coaxial system, which is we place a little bit larger needle to the lesion first, and then we insert the ablation antenna through that. So meanwhile, we can take a biopsy from that lesion when we place the coaxial needle.
You mean core for
Correct.
microwave?
Coaxial, yeah, it is to.
Oh no.
If you have, you can use it, but it's not right. Okay. Thank you.
Yeah. Oh, we don't. Yeah. So this is a step of local anesthesia. We can see the needle tip of the yeah. It's in good position.
Yeah.
So he is preparing to insert the microwave antenna to thorax cavity.
What gauge size is this one?
This one 18.
It looks like
18. No, 40.
Yeah, 18. No 40. before.
What is the ablation zone you expect to get with this antenna?
Sorry, what you mean? You mean
What
what?
is the size of ablation
Size?
that you expect? Yes, with this antenna, with the specific antenna that you're going to use, what is the expectation?
18 gauge.
那个
Yes,
老
this is
师
the size, but
Yeah.
how much do you think
Size.
you will
想问
ablate
一
it?
下，
Let
就
me
是
The
see.
question is,
长度嘛，是吧？
没有预期的一个消融的范围大概多少呢？用这个针。
Which is 3 centimeter, around 3 centimeter. You mean the size of the ablated zone, right?
Yes, yes, exactly.
Yeah,
The size of the
3 centimeter.
so you are going for an A0 ablation with 10 millimeter margin around the lesion. So is it a standard for you to go for a 10 millimeter margin around the tumor? Is that what you always target?
So you consider the size is much bigger than the size of the tumor, right?
老师就是想问一下，这个10毫米的一个肿瘤那个 margin 是必须的吗？就是每次做消融都会留一个10毫米的一个 margin 吗？
10毫米的 margin， 你说他是说你说就外扩的是吧？
对对对。
主任，他问这个肿瘤外界是外扩10毫米是吧？还是外扩几毫米？Yeah. Well, Dr. Xinye recommended the margin 5 to 10 millimeters. 5 to 10.
If you can, if you can maintain 1 centimeter, 10 millimeter, it is better, right?
Yeah.
How do you control the breathing of the patient? Do you ask him not to breathe? Do you tell him to hold his breath? How do you control the breathing?
You mean the breathing? Usually, if the patient can cooperate in the operation, So, we just ask her to breathe, to hold her breath, and then just insert the antenna. Usually, the breath holding is easy if the lesion located in the upper lobe. However, for lower lobe, sometimes the breath hold is difficult. So he just insert an extra 2 centimeter and make a scan to see whether the antenna is in the right position. No. So, no. So we can see the antenna is in good position, but however, the in microwave ablation, the tip must exceed the margin of 骨床。好，this is the bone window of the image. we can clearly see that the tip is still located inside the tumor. So we must insert antenna to exceed the tip of to outside the margin of the lesion to cover all the
I see that professor also tried to go more anterior to the anterior part of the chest wall by moving the antenna a little bit anteriorly.
I think probably he was just doing it because it is on the peripheral, the posterior and lateral margin rather than.
Yeah.
Good question.
Okay. This is it's now in the good position. So he's preparing to connect the microwave device and the antenna.
Is it possible to look at the last image again, please?
他想再看一下之前的那个上一个。You mean the last? You mean the
last scan?
The last scan?
Yes, the final position of the needle, please.
哦，最后一个，就是不是这个，就是他刚扫的那个，应该就是最底下这个，是这个是吧？这是刚扫的是吧？ Yeah, this one.
What will be the ablation protocol? How many minutes? How many watts?
No, 50 watts for this one. 50 watts.
For how many minutes?
How long?
Time
几分钟啊？
3, 5, 4 minutes.
Okay, we make a CT scan after 1 minute of ablation, and the total procedure, total ablation, maybe 3到4是吧？3 to 4 minutes. Yeah, we must. Yeah. We recommend it. We recommend a CT scan after 1 minute ablation to monitor the whole procedure.
And you do 50 watts for how many minutes?
Well, the ablation is still ongoing, so we.
No, the protocol says 50 watts for how many minutes in total?
3 to 4 minutes. 3 to 4 minutes.
4 minutes.
Yeah.
And that will give you an ablation zone of in excess of 3 centimeter, most likely. Are you going to do two stage? Are you going to pull the needle slightly backwards after a few minutes, or are you going to do it all in this position?
He's going to adjust the position of the antenna. So for this patient, changing antenna, the position is necessary to obtain the complete ablation. Yeah. Oh.
Professor repositioned a little bit the antenna, I see, has disconnected the ablation.
He just adjusts the antenna to the to the lower position of this lesion.
Now, do you have an anesthetist or anesthesiologist present during the procedure? Say, for example, if there is an issue, or is it just the IR team there?
We can see that this is quite well tolerated and the patient is not tachycardic and has a good pressure.
老师，我想问一下，就是如果有特殊情况的话，会有麻醉师在场吗？会有麻醉师陪着做完这个手术吗
Yeah, we have. Yeah.
We have.
We have anesthesia.
Okay.
The second protocol is the same as the first one. Again, 50 watts for 3-4 minutes.
刚才是烧了几分钟？烧了3分钟是吧？ Yeah, before adjusting the antenna, we 50 watts. 那个烧了几分钟啊？刚才那个50 watts 3 minutes, and then adjusting the antenna. And now the microwave is ongoing. Dr. Ye planned to ablate another 2 minutes. So that is 50 watts 3 minutes, and then adjusting the antenna 2 minutes, finished.
So basically, they are doing.
Professor will do a track ablation in the end, or no?
Drug ablation.
Track ablation.
Drug ablation. No, drug ablation. Okay. He withdraw the antenna.
Yep.
And
Alex, my experience with echo, what I in different organs is that you basically target a 2-point ablation. So we start slightly ahead of the lesion, and then we do a second point slightly behind the lesion, and that gives us better tumor control. You normally do track ablation. I think I prefer to do track ablation.
You mean 2-track ablation, double antenna?
No, not double antenna. Towards the end of the procedure, when you are withdrawing it, there is a track ablation protocol in echo.
Oh, track ablation.
And,
We do.
yes.
We do.
Right.
Dr. Eric from Philippines is asking, what are the risks involved in this procedure?
Sorry.
So okay, awesome. This is the final scan to see whether there is a bleeding or pneumothorax.
Yep.
Yeah, this is necessary for lung ablation. The operation is nearly completed. Yeah. Okay. Yeah. Yeah, we can see the boundary of the reactive GGO of the ablation. Yeah. The GGO fully covered the lesion. You can see it clearly.
Yeah.
Yeah. Bone window. Yeah, in bone window. You can see the lesion is in the center of the cavitation. Yeah. Yeah.
Congratulations for a very nice ablation.
Thanks.
Congratulations, well
Can
done.
we answer the question about possible complications during ablation?
Oh, okay. Dr. Alexis, Dr. is preparing the next operation. So during this gap, I prepared 3 cases of lung ablation to show you. Is that okay?
Yes, can we first cover the question that was asked? What are the possible complications that we expect from an ablation?
Yeah. I'm sorry. This is kind of loud in my place, so I can't clearly hear your question. Dr. Ye just want to show you the comparison pre-ablation and the CT image immediately after the ablation, post-ablation. Yeah, we can see it clearly.
Yeah.
The lesion was ablated.
The ablation.
I think Dr. Ni just mentioned the complications of the ablation here could be bleeding or pneumothorax.
Yes.
What about tumor seeding along the track? What's your experience of this possibility in your patients?
There has suddenly been reported that there is a possibility of seed tracking, although using the protocol of ablation, of track ablation, we haven't seen any of these seedings. Anecdotally, there are reports in the literature on seeding track. I don't know, what is your experience?
Well, in my case, I haven't come across yet, but I know I've seen cases, reports from various centers of particularly in lung, because you need one cancer cell to cause that, and I think because the studies are limited, when we have big numbers, probably then we would be able to say what is the exact incidence. We do bone, liver, kidney, and lungs. And so far in our experience, I haven't come across in my practice.
There is another question as to how many metastatic lesions would you treat?
Depends on what is the definition of a oligometastatic disease in your center. So it is an ever-expanding number. Started with 3, 5. We've seen centers doing 9 in lung, bilateral. So, you know, I think there is no right or wrong figure or number in this. I think it is up to the multidisciplinary team and the patient at that center to come to it.
Yes,
That's what we do in our practice.
Our limit usually is 3 to 5 with up to 3 centimeters maximum size.
Yes.
That is what we usually do.
So, okay, is it right? Depend on the size of the metastasis. So if it is small and if the background lung is normal, we can do without thinking about the lung compromise, right? If it is bigger one with a background bad lung, you have to think of damage to the lung and respiratory problem. So I think we have limited experience, but what we do is if it's a good lung without any emphysema or whatever, we do. But if it is bad lung, we have a bit cautious.
Okay. Dana, they are ready to show something from the hospital. I see them on the camera.
Yeah, I think we are about to. Hello, Dr. Ni. Hello. Your mic is mute. Hi. So, are we moving on to the next case introduction, or are we going to discuss the first case now?
Yeah. So, I just want to introduce 3 cases of lung ablation in this gap. Okay. Let me share my PPT. Yeah. Good afternoon, everybody. Here I reported 3 cases of microwave ablation for early stage lung cancer. Case 1 is a 76 years old male patient. He complained of bloody sputum for 2 weeks and suffered for hypertension and severe emphysema. His smoking history is 40 years with 20 pieces per day. This is a baseline CT image. We can observe a 4 centimeter solid lesion in the right upper lobe, and the clinical stage is 1B. Owing to his poor pulmonary function, surgical resection cannot be performed. So we perform lung biopsy and microwave ablation simultaneously. Here we showed the detailed procedures of the treatment. After lung biopsy, double microwave antennas were inserted into the lesion to complete the ablation. Antennas were adjusted in multiple directions to cover the boundary of the cancer. The pathology examination showed it's adenocarcinoma. Here is a follow-up. We can see the reactive GGO completely covers the lesion 24 hours post-ablation, and it significantly decreased on 5 months after ablation, and developed as fibrocord 4 years after ablation. Case 2 is a 68 years old male patient who complained of a right lung lesion by routine CT scan 1 month ago. He suffered coronary heart disease and emphysema. Smoking history is 40 years with 30 pieces per day. Here is the CT and PET, baseline CT and the PET CT scan of this lesion. We can see 1.8 centimeter solid lesion in the right lower lobe, and the clinical stage is 1A2. His pulmonary and cardiac function was also poor, so surgical resection was highly risky. We performed lung biopsy and microwave ablation simultaneously. After pre-ablation planning, biopsy and microwave ablation were performed successfully. Pathologic results showed adenocarcinoma. The reactive GGO fully covered the lesion 24 hours post-ablation. The ablated lesion gradually shrunk 1 month, 9 months, 1.5 year, 2 years after ablation. However, the lesion significantly enlarged 2.5 years after ablation without any other distant metastasis. We confirmed it as local recurrence. So we performed repeat microwave ablation for the recurrent cancer. And after 6 months follow-up, the local efficiency was satisfied, and the OS for this patient is over 3 years. Case 3 was a 69 years old female patient who complained of a left lung single nodule by routine CT examination. He suffered COPD for over 20 years. The 4 centimeter lesion located in the left upper lobe, and the clinical stage was 1D. FEV1 was 62%, and LVEF was 50%. This patient refused the surgical treatment. Here we show the detailed procedures of biopsy and the microwave ablation. Pathological results show the adenocarcinoma. We can see the reactive GGO fully covers the lesion on the immediately post-ablative CT image. There was no enhancement or enlargement on the enhanced CT 2 months post-ablation. And we just as a complete ablation. Long-term follow-up showed the ablated lesion was stable and gradually shrunk. 7 months, so 1 year, 2 years, so 4 years, 5 years, and it developed as fibropoder on 5 years. Okay, here is all my presentation today. Thanks for your attention.
Thank you, Dr. Ni. Thank you.
Thank you very much.
Thank you very
Can we
much.
ask 2 questions? On case number 2, did you perform a biopsy on the case number 2, on the second case?
Hello, Dr. Ni, can you hear us?
Yes, number 2.
Okay.
Okay, number 2.
On the case number 2, you said that the patient had this opacity. Did you do a new biopsy when you had this nodule, the one you showed, the case that you showed, the case number 2 that you showed? You showed that it was in increased size. Did you do a new biopsy when this size increased of the lesion?
Yeah, you mean, we do the biopsy. The biopsy. This is a biopsy. You know, this we use the core biopsy either to obtain the pathological specimen, and usually for this kind of patient, we we send this segment to quick pathological examination. We got the positive positive results of this lesion, and it's confirmed it's cancer, no matter what kind of it. And we then insert the microwave ablation and to treat the lesion.
So you do a quick pathology in the CT scan when you do before the ablation, correct? You do a quick pathology.
Quick, you mean quick resolution of the pathology examination?
Yes, I mean that you do it in the same time that you do the ablation. You do the biopsy before, and you do a quick pathology report.
We do the biopsy before the ablation, and we do quick. We do quick histology examination. Frozen specimens.
Also, I saw that you treated quite a lot of lesions that were 4 centimeters. Is that your cutoff? Do you treat up to 4 centimeters, or do you go bigger? What is the standard size that you usually treat?
4 centimeters. We generally we treated some patients with lesions over 4 centimeters. Frankly speaking, the result and the efficiency was not so satisfied. So it's real. Okay. So for the moment, we treat most non-nodules less than 4 centimeters.
Okay, I'm sorry to interrupt the operation. They already prepped the patient, so we're going to the OR now.
Okay.第二例，这个第二例它是GGO，这个哦，化脓了。是这个当然，对，夹不住。说话是介绍那么第二个，没介绍是吧？现在没。
So this is the second case. This is a female patient, 69 years old. She complained. She found a GGO lesion in left lung 1 year ago, but the lesion was gradually enlarged. So 3 days ago, a CT scan was conducted and showed that the GGO nodules enlarged from 6 millimeter to 11 millimeter. She suffered hypertension and thyroid nodules. And okay, the patient suffered severe insomnia, and she refused surgical treatment.
Will you do a biopsy in this case?
Yeah. For this case, we will do biopsy and microwave ablation simultaneous with the permission of the patient. and she just you know she wants to do everything in one session. Okay, so the lesion is very clear on CT scan on the left upper lobe. Well, okay, he is measuring the size of the nodule and ablated zone. The diameter is on the 11 millimeters. So yeah.
什么？
这是脖侧，不是脖侧啊，
不是
3毫米的
2
哦，2毫米。Yeah, the slice of this is the 2.5 millimeter slice of the CT. This is the planned puncture pathway. And this is the depth of the thoracic wall. Yeah, he's making the marker. He's making the marker of the puncture. Okay, here's the marker.
this is a biopsy automatic or semi-automatic needle for the biopsy, correct?
Yeah, correct. This is a biopsy needle. Actually, this is a semi-auto biopsy system, biopsy needle. But still, the first step is local anesthesia. And okay. From this side, you can see clearly. This is local anesthesia with a little cane. And then we usually take a CT scan to see the position of the tip. Position of the tip and the lesion. Yeah, okay. So we can see the marker and the puncture point of the chest wall is not bad. So we can insert biopsy needle and through this pathway. So this is upper direction, up, and down. This is down, lower. So we can see the lesion just occupied 1, 2, 3, 4. This 4 slices, and the slice of this scan of the scan is 2.5 millimeter.
We are seeing the room right now. We are seeing the operation room, the CT scan. Not the images.
Ablation. Oh, okay.
I see that this machine has 2 ports, which means that you can do a simultaneous ablation with 2 microwave antennas. Is that correct?
Yeah. This machine can connect 2 antennas simultaneously together. So for GGO lesion, we advise and we recommend to insert a microwave antenna in prior to biopsy needle.
Why is that?
Well, to ensure the reason we do this is to ensure the microwave antenna is in the right position and finish the ablation. Yeah.
I suppose that in case of pneumothorax or hemorrhage, you have the needle in place, and that will allow you to do the ablation. If you do the biopsy and you have a pneumothorax, then that might be a problem for placing the ablation needle, for placing the microwave probe.
如果要进的胸容针，会不会有一些气胸啊，或者并发症？会不会
有的时候或者有的时候就可以直接处理，支管把气胸抽出来。
If pneumothorax occurred, we have some methods. We can insert the thorax tube to exclude the air, to exclude the air pollution. So that's not a that's not a big problem for. That's not a big problem for the procedure, for the operation.
As if you're
Aren't you afraid of? Sorry, aren't you afraid of hitting the microwave or damaging the microwave probe with a biopsy needle?
The reason is that we insert the microwave antenna firstly, because we want the microwave antenna is in the best position to finish, to best the position to cover the GGO lesion. If we insert the biopsy and finish and do biopsy in prior to a microwave, you can see sometimes there will be bleeding, and the bleeding area will cover the lesion and make the boundary of the lesion invisible in CT scan. So we insert the microwave antenna and just to anchor the lesion. So no matter there is bleeding or no bleeding, we can do ablation successfully.
基本上这个先消融后化解哈。就不防止它出血。
Do you think that a coaxial system with long, access needle would be helpful?
System? What system?
A coaxial
system. You mean the coaxial system of biopsy and microwave ablation?
Yes.
You mean that? You mean that system? Usually, it may be helpful sometimes. Just a moment. Okay. Dr. Ye just want to show you that the microwave antenna is in good position. Yeah.
Kissing the posterior.
Yeah, we can he just advised we can discuss some questions after the operation.
Okay.
Okay. Yeah. Obviously, he need an extra distance.
Because the needle is just kissing the posterior end of the lesion.
Yeah. He inserted another 1 centimeter just inside, and another CT scan to see whether it's good or not. Okay. Yeah. Okay. Okay. The antenna is, yeah. So now we can see the antenna. The antenna itself can be a marker. Can be a marker for biopsy needle.
就是为了防止出血，可以先消融一下，再去活检啊，不影响病人情。消融1分钟，再去活检，不影响病人情。
Yeah. If we concern the bleeding of the touched lesion, we can even ablate 1 minute in prior to lung biopsy. It doesn't matter the it doesn't matter the pathological results.
Okay.
Yeah, microwave doesn't 1 minute microwave is doesn't matter the pathological results, but it has excellent efficiency to prevent bleeding. True. Yeah, he just placed the biopsy needle parallel to the antenna, parallel to the microwave antenna.
37了吗？
啊，
是的
，27。
好，这个看活检已经快到位了，这个讲一讲。
Yeah, the biopsy needle is approaching. Boom. Yeah. Yeah. Okay. So this is the microwave, and this is the biopsy needle. And we need extra. No. 往回拉。对，哎，好。We need extra 2 centimeter.
那个活检的，看活检太接近的话，活检它再近半米，箭头那个别小手，再近半米，补创，啊那个对上对，到那对，和第2次比，第3次比。
So now we can make a comparison of the previous CT scan to make sure the biopsy. Yeah. So
这个那个第2次下一次，上一次对，别这一次啊。
No, okay. So these two image is in the same slice. So
这个
yeah.
这个之前，现在这个位置，现在这个活检的位置到了这个。
Yeah. So we just compare the image of the present image and the previous plan image. We can see the microwave antenna and biopsy antenna is placed as our plan.
Well, looks good.
Thank you.
You do 1 minute ablation.
So probably you are going to
Okay,
take a 10 millimeter core, single click rather than double click. Double click.
Okay, double. Yeah, double. And insert. Place the biopsy. Yeah. Okay. So we still need another scan. To ensure the tip of the biopsy needle is in the right position. Okay. Here we see.
Moment of truth.
Yeah.
保证了核点谁看这个上核点，看到这个弧窗。
Boom. Yeah. You see. Yeah.
Well done. Well done.
Yeah. Thank you. Yeah. So we are showing the
Core.
But yeah, we are showing the specimen. Yeah, good. It's good. Yeah. Yeah. It's fixed immediately and will be sent for pathological examination. Take another one.
So you are using a coaxial technique for the biopsy. So you have the initial needle inside and you're going through the same passage and taking multiple samples.
Yeah. So we go through the so this is a coaxial needle. So the advantage is that we can get specimen multiple times. The third one. Okay, the antenna, microwave antenna has been connected, and the microwave ablation is ongoing.
What settings have you on now?
We are doing the ablation now.
Yes, but at what setting? How many watts, how many minutes?
Just a minute. I must ask him. 还是想问问参数
啊？
参数，希望
可以
参数。
这个就是40万，
哦
因为GGO 有40万，
哦
40万大约是在3到4分钟。
哦，
你活检以后可能出血，那个可能出血，那这个我们看一下。但是这样的先插消融针后去活检，能够保证活检的准确性。
嗯。
你消融以后取了活检没有出血，这个是开机。
这个没有消了，
消了，刚才消了
了一部分。哦。
开机。
Yeah, the setting is 40 watts, 3 to 4 minutes for this small CGO lesion. And
is he going to come slightly backwards while he's ablating, or he is going to do single station?
Actually, this is you can say this is no bleeding, right?
Yep.
The bleeding because before biopsy, Dr. Ye performed the 1 minute microwave ablation. You can see that the bleeding is significantly decreased. It's much less bleeding.
Did the professor send both samples for fast biopsy, or did he put one formalin and one for fast?
I mean, fast examination of the sample. For GGO lesion. For GGO lesion
samples.
No. For GGO lesion, fast histology examination is challenging. So we don't do fast examination. So both so all the samples are fixed by formalin and just the regular histology, just a regular histology examination. No, we call this is real-time CT monitor for the microwave ablation. So we advise to take CT image during the procedure to monitor the radiology image. Usually we also take another sample of through the same through the same tube that which is the post ablation sample. To increase the positive rate of
you want to confirm histologically tissue necrosis.
Tissue necrosis. Please, just a minute. Okay, 3 minutes. He withdraws the antenna, and the operation is almost finished.
Good case, well done.
再往上一点，再往上打，再往上，快点，小龙有点气胸啊。
好 ，slightly pneumothorax。
这个标配就是那个什么那个一个词。
OK。
上一次，这个再上一次，再上一次，就是下一次，就这两个是完全是对全部。
Yeah, so there's a comparison.
这样就是有点气胸，不用处理啊，这个气胸。
OK.
In our experience, in such small pneumothorax, we will just, and without any problems of respiration, we will just leave the patient lying on his back and recontrol.
Yeah, you are right.
I agree with it. That's what we normally do. This is probably even less than 5%.
As we saw in the monitor, the saturation did not drop. It was good. The pneumothorax is small, so there is no need for an extra maneuver at this point.
Well done.
Okay, thank you. We are lucky. Okay.
Congratulations. Well done. Alex, do you use a coaxial system for such ablations?
几个下颌有，现在没了，现在就是这样的了，这应该是这个多，就这个。
Sorry, can't hear you, dear.
Professor Alex, you're mute.
We usually do a coaxial biopsy, but for the ablation, we go with one needle directly, like the one you saw here. My questions would be for them for the biopsy, whether you risk to damage the needle, the microwave needle with the biopsy needle when you have both so close. And my second question is, would there be a risk of having heat transmitted along the metal of the biopsy coaxial shaft and having problems there? But I suppose they will answer these questions here. So congratulations for the excellent cases. Thank you very much. These were very teaching cases, and I think everybody was really impressed for the quality and the good results. So congratulations. Thank you again for this excellent lesson.
Dr. Ni, you're mute. Yeah, good.
Do the panelists have some questions for the presenter of the cases?